My name is Juan Alderuccio from the University of Miami Silvestre Comprehensive Cancer Center, and we are here today at ICML 18, Lugano, where on behalf of all my co-investigators, I will be presenting the preliminary results of LOTIS-7 clinical trial. LOTIS-7 clinical trial is a multicenter study that evaluates the combination of loncastuximab plus several other agents, including glofitamab. In the current presentation, we will present data on the combination of loncastuximab plus glofitamab in relapsed refractory diffuse large B-cell lymphoma. The LOTIS-7 presents two phases. The initial phase is dose escalation, where patients receive loncastuximab at 90, 120, and 150 microgram per kilo with the approved dose of glofitamab in indolent and aggressive histologies. Patients require at least 2 or more lines of therapy. In the dose expansion, patients receive loncastuximab for the first 2 doses at 120 or 150 microgram per kilo and approved dose of glofitamab, and histology only concentrates on aggressive such as diffuse large B-cell lymphoma, high-grade B-cell lymphoma, grade 3B follicular lymphoma, and transformed follicular lymphoma. Patients post-autologous stem cell transplant and CAR T-cell were included as long as relapse occurred more than 100 days post-cellular therapy. On the treatment schedule included obinutuzumab on day 1. On day 2, patients received loncastuximab at 120 or 150 microgram per kilo for the first 2 doses based on the dose level. And on day 8, received glofitamab that followed the regular ramp-up. Starting on cycle 2, patients received on the same day loncastuximab and glofitamab, and up to 8 doses of loncastuximab and up to 12 doses of glofitamab were allowed in the study protocol. In this preliminary analysis, we included 41 patients that received at least 1 dose of therapy and 30 patients that underwent a disease response. Among the 41 patients that received at least 1 dose of therapy, the most common adverse event included neutropenia that was 24%, and interestingly, this is lower than it has been previously reported as single agent with single agent loncastuximab and single agent glofitamab. Other adverse events included anemia, increasing AST, GGT, and thrombocytopenia, but numbers are small. Neutropenia was also the most common cause for dose delays during the study period for both drugs, and only 1 patient required dose reduction of loncastuximab. Interestingly, when we concentrate the toxicity about cytokine release syndrome and ICANS, the incidence of cytokine release syndrome was low, with majority of the patients presented grade 1, and only 3 patients in the 120 dose level. 2 patients presented grade 2 and 1 patient presented grade 3. No grade 4 CRS occurred. 3 patients experienced ICANS, all grade 1 and 1 case of grade 2. No grade 3 or higher ICANS occurred. In the safety analysis, the overall response rate across all those levels was 97%, with a complete response rate close to 87%. Importantly, the median duration of response was not reached on both those levels, and the time to first CR was 42 days in patients in the 150 microgram per kilo compared to 80 days in the 120 microgram per kilo dose level of loncastuximab. Regarding the duration of response, 26 patients achieved a complete response, and among them, 25 remain on CR at the last time of follow-up. Now, in conclusion, loncastuximab with glofitamab induced high responses in patients with relapsed refractory diffuse large B-cell lymphoma based on the lower incidence of CRS and higher and shorter time from a treatment initiation to CR, the decision is to proceed with 150 microgram per kilo as the further dose expanding this clinical trial, aiming to include a total of 100 patients. I think this data is preliminary, and we need to continue expanding the study cohort and following the patient data. But I think it's highly promising and definitely can be an option for patients that are not eligible or don't have access to CAR T cell. This is an off-the-shelf therapy. The patient can start the therapy sooner than with cellular products. And the time to CR was only 42 days, but importantly, that was the first response assessment. I think also will be important to assess ctDNA data to see how deep these responses are until we are able to follow the patient for an appropriate period of time to assess the duration of these responses. Thank you.